So now I'm going to just briefly discuss what drugs do we have available already that are FDA approved for other indications that are in our armamentarium to treat patients with GIST. So what we're talking about here is the widespread progression situation where GIST is spread throughout the individual's body. And so Imatinib is not working anymore. We've used Sunitinib. We've had some good results with Sunitinib for a period of time, but the tumor has become resistant. So we already talked about this. So I just wanted to mention this, that dose escalating from 400 milligrams to 800 milligrams when a patient becomes resistant to 400 milligram results in 3% shrinkage. And this is data from one of those clinical trials just using size, and stable disease rate of another 28%. So about 1 in 3 patients benefit from dose escalation. So now I'm going to give some information about Sunitinib. So Sunitinib was looked at in a clinical trial of patients who were intolerant or resistant to Imatinib, and this is Sunitinib in this slide, in its former name, and it was compared to placebo, as I mentioned, and the partial response rate was 7%. So about 7% of patients treated with Sunitinib had marked significant shrinkage of their tumor. And what was impressive is that another 58% had stabilization of disease. So about 65% of patients had partial response or stable disease. And there was about 20% of patients who had stable disease for more than 6 months. And only about 20% of patients had early progression of disease. So Sunitinib clearly has some activity in shrinking tumors and preventing them from growing. And in fact, the median time to progression, or the number of weeks on average that it takes for a patient's tumor to start growing again, was 27 weeks. So that's quite substantial, more than 6 months. And this is a curve that we've shown before, just showing that there is a good benefit to this drug in terms of keeping a tumor, preventing it from growing. Now, we did a study a number of years ago on our GIST patients who were treated with Imatinib, and we found that those patients who do very poorly on Imatinib had very high expression of VEGF in their tumors. VEGF and VEGF receptor are also targets of Sunitinib. So one strategy that we're considering looking into is whether or not treating patients with this high expression of VEGF should be something that we should be doing with Sunitinib. So then later in the next session, Dr. Gupta is going to discuss therapy for limited progression and some of the ways we manage limited progression here at MD Anderson, as shown on this slide. I'm just going to skip over that. He's going to go into more detail, but I'm going to discuss other systemic therapies. So what do we do when Imatinib and Sunitinib don't work, and clinical trials don't work, or clinical trials are not available, or a patient's not eligible for clinical trials because of the enrollment criteria? Or perhaps the clinical trial has a placebo arm and one does not want to be randomized to placebo. And so on the left-hand side of this slide, you can see a list of agents: Nilotinib, Dasatinib, Sorafenib, Masitinib, Vitalinib, and Motesinib. Got that alphabet soup? Oh, so yeah, Tasigna. So Nilotinib is also called Tasigna. Dasatinib is also called Sprycel. Sorafenib is also called Nexivar. And there's a newer one that's not on here yet, that's not really been looked at yet in GIST, but is a KIT inhibitor called Pazopanib or Votrient. And we're starting to look at that. And then these others aren't really so much available in the US. Now, if you look over on the far right of the slide, what you can see a table, a column that I call Efficacy. And so again, because of the way these trials are done, we're only looking at tumor shrinkage. We don't know what's happening to the internal characteristics of the tumor because of the way these trials were done, other than the Dasatinib trial. The Dasatinib trial included as partial response, decrease in contrast enhancement. So as single agent, Nilotinib has a partial response rate of about 10% and a stable disease rate of about 37%. Dasatinib, about 8% tumor shrinkage. 30% of the time, the tumor stops growing. Sorafenib, or Nexivar, in this phase 2 study, in patients who had already had Imatinib, had already had Sunitinib, treated with Sorafenib or Nexivar, 14% of the time, they have stable disease. They have a partial response or shrinkage of their tumors, and about 62% of the time, they have frank stabilization of disease. Imatinib is a trial that's being looked at in frontline in Europe. There are a couple of sites in the United States, and it's looking at partial response rate of 21.5%, stable disease rate of 75%. A lot of the 75% stable disease patients are actually responders, but they're not counted as responders because they're still using the RECIST size-based criteria. So this is just a waterfall plot here showing radiographic response. And so progressive disease is on top, partial response is down low. And this was presented at ASCO a couple of years ago, showing that nearly half of the patients had stabilization of their tumors or shrinkage of their tumors in the yellow and in the red area here. This represents patients who had no growth of their tumor, and then this part of the bar graph represents patients whose tumors grew on Sorafenib. So more than half of patients really had an arrest in growth of their tumor or some shrinkage of their tumor, and that was captured on progression-free survival over here on the right side. So it clearly has some activity. And then Michael Montemuro from Switzerland looked at a set of European patients who were treated with Nilotinib or Tasigna in third line, and he found that 47%, again about half of the patients, had partial response or stable disease, and about another 40%, this lasted for more than 3 months. And you can see, again, benefit from patients in these curves. So there is some prospective, that was retrospective, there is some prospective data on Nilotinib where patients were put on a trial and treated with Nilotinib, and this was initially done in a phase 1 setting looking at combination of Imatinib plus Nilotinib. But if you look at the yellow column, these are patients treated with Nilotinib only, and they found that 67% of patients, their tumor had stopped growing for 4 months, 44% had stopped growing for 6 months or more. And so now we're looking at Nilotinib in frontline. So in this study, patients with newly diagnosed GIST, who have just been diagnosed with metastatic GIST, MD Anderson, and globally, there is a study that is taking these patients and randomizing them to Nilotinib or Imatinib to figure out whether one is better than the other or whether they're equivalent, and to get some idea about side effects. And that study is ongoing currently. It's available at MD Anderson and other places. And then there's also a lot of interest about HSP90 inhibitors. I'm just going to mention that. Although it's in clinical trial, it's not available nor FDA approved yet. And Dr. Hong will discuss that trial, this agent and these trials later today. But they have shown efficacy, and everybody's still very excited about these drugs, although the initial phase 3 study was closed. But you can see in this example a large tumor, and patient has had clear benefit. So I'm just going to end by discussing a little bit of my philosophy about these clinical trials. So when I see patients being treated with phase 2 studies, if the new agent that they're going to be treated with is a KIT inhibitor or a PDGF receptor inhibitor, then I think that that agent is perfectly fine as a single agent. But if the new study that a GIST patient is looking at for a clinical trial and the new agent is not a KIT inhibitor, in fact, it does something else, it blocks some other molecule or binds to some other protein or has a different mechanism, then those agents should be combined with imatinib or combined with some other KIT inhibitor. I would not design a trial nor recommend a patient or refer a patient to a trial that had an agent that had no activity against KIT, because we know from several different pieces of data, some published, some unpublished, some personal experience, that discontinuing KIT inhibition results in acceleration of growth of the tumors. So we generally look at combination studies for these agents. And so I'm going to end there, and we have a little bit of time for questions before we move on to the next topic. So I'd like to again thank you for your attention, and I'll be happy to answer any questions. Questions?
Since bleeding seems to be a long-term solution, do you envision patients 10 years plus on the therapy?
Yeah.
And if that's the case, will we see the cost of Gleevec eventually coming down?
Well, the answer to your first question is easy. She's right behind you. And there are a number of patients in the room that have been on Gleevec that long or longer.
And that'll be more of the trend. Could be more of the trend.
I hope so. You know, if it means patients are living longer, yeah. As far as the cost, I think that's a complicated issue and way beyond my ability to really discuss. I mean, it's complicated. You know, with all these changes in insurance, what's going to happen with these types of drugs? It's already, we're already frustrated. Whether or not that's going to get better or worse, nobody really knows. There's new drugs coming out all the time. And so it's a complicated issue. Wish I had an answer. Any other questions? No? Okay, well, thank you guys very much.